Can we start now or can we wait for another 3 to 4 minutes? Mm-hmm. 2 minutes. Yeah, good afternoon, everyone. So we'll start this session on glaucoma. It is called Glaucoma Perfecting the Art of Alternate Paths. So I would like to call upon our chairman, Dr. Sriram Ramlingam, on the dais, please. And our panelists, no, dais is here, sir. Our panelist, Dr. Rashmi Krishnamurthy, please, ma'am. Dr. Sandhya, she must be busy outside organizing. Dr. Vidya Devi, and myself in there. So now we have 1.5 hours session. Please feel free to ask any questions anytime, but we will start the sessions slightly one order away from the main thing. We need more audience, so they are coming after lunch. So we'll start with Dr. Vidya, lasers in glaucoma. Then we'll take up the keynote talk, ma'am. Is it okay? Dr. Rashmi? Yeah. Dr. Vidya, please. She is a assistant professor at associate professor at Minto Eye Hospital. Even the mic is not cooperating with me. Huh? She will be speaking on lasers in glaucoma. Dr. Vidya, please.
Good afternoon. Hello. Hello. Good afternoon, everyone. At the outset, I would like to thank BOS for giving me this opportunity. I'll be talking about lasers in glaucoma. We all know that some of the lasers which are used in glaucoma, the commonest being the argon blue laser and the Nd:YAG laser. The properties of lasers are monochromatic, coherent, and they run parallelly and they have a good brightness. They basically interact with tissues as photocoagulation, photodisruption, and photoablation. We can classify lasers used in glaucoma as the lasers used in open angle glaucoma to enhance the outflow. We use laser trabeculoplasty. To decrease the inflow, we use cyclophotocoagulation. Then the lasers used in angle closure glaucoma to relieve the pupillary block, we do laser iridotomy. To modify the iris contour, we do laser iridoplasty. And to decrease the inflow reduction, we do cytophotocoagulation. Lasers can also be used post-operatively, either to cause laser suturolysis, to do sclerostomy, or to do goniopunctures also. The most commonest type of laser which is being used is laser iridotomy. So this basically connects the anterior and posterior chamber in order to relieve the pupillary block. The main indications are, definitive indications are, it is used in spectrum of angle closures and in acute attacks of angle closure glaucoma, creeping angle closure, mixed mechanism glaucoma, and in pupillary block secondary to phacomorphic lens or in iris bombay. The relative indications are in a critically narrow angle in an asymptomatic patient or in younger patients who has to travel a long distance for medical care, and a patient having narrow angles with positive provocative tests. So what we do is, once a patient is chosen for laser iridotomy, we put pilocarpine 1% eye drops to induce meiosis. This in turn causes stretching and thinning of iris. And we also use proparacan eye drops. We can use either Abraham lens or Wies lens. These lenses are used to concentrate the laser energy and to minimize the spot size and magnify the target. In case you are using an Nd:YAG laser, these are the parameters which are set, and we usually choose 11 or 1 o'clock position, which is covered by your upper eyelid, in order to avoid the ghost images. Usually we avoid iris blood vessels, and iris crypts are chosen because it is thinner in that area and laser penetrates easily. The end point is you have to look for pigment epithelium coming out into the anterior chamber. We can also use argon laser. In light colored irides, we use long pulse argon laser. In dark brown irides, we use short pulse argon laser with these power settings. Usually what we do is a single area is treated with superimposed applications until you get a perforation. Once you see that pigment fumes coming into anterior chamber, it's called as a smoke sign or also called as a waterfall sign. This argon and Nd:YAG laser can be combined together. This technique is usually used in patients with dark brown irides or patients who are on chronic anticoagulant therapy, wherein argon laser basically coagulates the vessels and it attenuates the iris thickness to 1/4 of it. And then the Nd:YAG laser is used to create this thing in the center of that argon laser where you are done to complete the iridotomy. Post laser, we give steroid drops 4 times a day for a week, then acetazolamide twice a day for 3 days, and a drop of topical AGM is given, and patient should be rechecked after 7 days to check for IOP as well as patency of iridotomy. Then coming to next type of laser, laser peripheral iridoplasty. It's also called as gonioplasty. It's an effective means of opening the oppositionally closed angle. We use argon laser here with these parameters. It causes contraction of iris at the periphery and physically opens the angle. Usually we give around 10 to 20 spots, all 360 degree of your peripheral iris. The commonest indication is plateau iris syndrome. and nanophthalmus. And whenever you want to do ALT or SLT, just to facilitate that, we do this. It's the laser is given all 360 degree, around 10 to 20 spots. Then coming to laser iridoplasty, it's a non-invasive technique and it increases outflow. We can use either argon laser trabeculoplasty or you can go ahead with selective laser trabeculoplasty. The lenses used are Goldman, rich trabeculoplasty lens, Thorpe's lens. These three lenses are used when you're doing ALT, and Latina lens is used when you're doing SLT. The mechanism is the laser energy is absorbed by the pigment trabecular meshwork, causes the shrinkage of your collagen trabecular MLA, opens up the intertrabecular spaces and eliminates the trabecular spaces and thus opens. The difference between ALT and SLT is ALT we use argon laser and we choose the target area, that is the junction between ATM and PTM, and we give 50 micrometer spot size, and you should wait for blanching or you should look for a small bubble in the bubble coming out from there. While in SLT we use double frequency Nd:YAG laser, and it is basically targeted at pigment trabecular meshwork, and the spot size is around 400 micrometers. The commonest indications for laser trabeculoplasty are chronic open angle glaucoma, exfoliative syndrome, pigmentary glaucoma, and glaucoma secondary to aphakia, pseudophakia. Lasers can also be used in malignant glaucoma. We can use either Nd:YAG laser or argon laser. This is done at anterior hyaloid phase or between the iris process, or it can also directly hit the posterior capsule. We can do cytophotocoagulation by three techniques. Either transcleral using Nd:YAG laser, argon laser, diode laser. The commonest one is diode, which we do by transcleral method. We can also use carbon dioxide laser in order to do a flap secondary to your trabeculectomy. Once the trabeculectomy flap is taken out, you do remaining sclera. You can take out remaining sclera to create the ostium, and also you can take out trabecular meshwork also until your aqueous percolates. You can do suture lysis using lasers. Usually argon laser is used. The most important thing is you should do, if you are doing suture lysis, it should be done 15 days just after the surgery for it to be effective. Or you can do 2 months or more, little more if you are using mitomycin C. It can also be used in patients with failed filtering site. The newer ones are femtolaser and examer laser. The femtolaser is usually used ab externo and examer ab interno. Lasers can also be used for cyclodialysis cleft to open or close. It can be used for synecholysis, gonophotocoagulation. Laser can also be used for goniopuncturing, vitreolysis, or modify the bleb. In summary, lasers are an important part of armamentarium in the management of glaucoma. Several situations exist when laser therapy may prove beneficial to control intraocular pressure along with medical therapy to enhance the quality of life while preserving visual function. Thank you.
Thank you, Dr. Vidya. Are there any questions from the audience? Let us not be one-sided. If there are any questions, we'll take up 1 or 2 questions, or else we'll move on to the next speakers. Then in the end, we can have a discussion whenever the time is left. Sandhya, please come as a panelist. Dr. Rashmi. Now I would like to call upon our keynote talk speaker, Dr. Rashmi Krishnamurthy. She is a senior consultant at L.V. Prasad Eye Institute, Hyderabad. She has taken all the risk and efforts in traveling from Hyderabad with all those outages happening in the airline field. She will be talking on MIGS challenges and beyond. We know MIGS, MICS, MIVS. Now she will touch upon MIGS. Over to Dr. Rashmi, please.
Can you reset the time?
Thank you. I thank BOS and Dr. Anuradha for giving me this opportunity. It's my pleasure to be presenting here in my hometown. So I'll be talking on MIGS rather than saying a MIGS revolution, MIGS storm, whatever it is going to stay with us here. Conventional trabeculectomy is the gold standard filtration procedure that we have been doing all these years, and it is based on a scleral flap and a conjunctival flap. If it is working well in early 3 months, and it will definitely going to work for more than 1 year, and the success rate has been around 88% for 20 years. But there are some very mild complications to very severe sight-threatening complications with trap. And if it's a failure, then we do have implants, but that is also associated with complications like failure and then its own associated problems. So can we avoid these complications? Yes, definitely. With MIGS, it's been causing minimal trauma to the tissue, and it has a high safety profile with modest efficacy, faster operating time, and rapid recovery. So what are the advantages? It spares the conjunctiva and sclera for future trap if you want. There's no bleb, so there is no tension with bleb-related problems. The main pathology in POAG is trap meshwork, so it bypasses that resistance, and there is decrease in the dependence on AGM. So there are a lot of MIGs that have been introduced based on the target tissue that it works on, but we are going to discuss on those who work on Schlemm's canal. Basic indications, as far as I am concerned, or most of the common indications are open angle glaucoma, be it primary or secondary, pseudoexfoliation glaucoma, and it can be used in post prior incisional surgery. That is where my mixed journey started, in failed traps and failed AGV. Contraindications are angle closure, new vessels, those who need very low target IOP or have very high preoperative IOP, and allergy to AGM is a relative contraindication. If they're allergic to all medications, then better to avoid mix. And of course, bleeding disorders, because there is a tendency for bleeding. Now the MIGs available in India are KDB, Bang, GAT, and iStent. KDB is based on Barkhan's goniotomy, which was introduced in 1948. This is an animated video from the company. After injecting viscoelastic into the anterior chamber as well as onto the corneal surface, a good visualization is very important for all the MIGs. So we use direct gonio lens, Schwann-Jacob, for the visualization of the angle. At any point of time, it's very important that we see the structures very clearly. As smaller the incision, it is better. KDB has a tip which pierces, there is a ramp which elevates, and there are dual blades which cut the trabecular meshwork. Microscope adjustments is very crucial. We need to have around 35 to 45 degrees of angulation, both the microscope and the eyepiece and the patient's head. So the patient's head has to be away from the surgeon. So this is a patient. Usually the results are better if we combine with cataract surgery. Some do it before and some do it after. I prefer to do it after surgery. Once the settings are done, microscope, visco in the eye, visco on the cornea, direct gonio lens is placed, and the angle structures are visualized. Better to do always with high magnification. And the smaller the incision is better. I would prefer to do it with the side port because the amount of helon that escapes is less. And this is meet and greet. Start from the center and do the goniotomy as far as we can see through the lens. And then again start from the other end and meet the point where it was started. So once we complete, there is some blood ooze, which is a good sign. It means that we have done the procedure in the Schlemm's canal. There are some tips of trabecular meshwork which can be removed manually with the help of micro scissors. This is the appearance. We can see clearing in the center of the pigmented trabecular meshwork. We have published the first paper from India on KDB mix, 6-month results. We included POAG, PXFG with advanced glaucoma. And we can see that there is significant reduction in both AGM as well as IOP. Whatever complications happen, they do resolve within a week. And our results are comparable to what is published. So KDB is definitely safe, effective, both in reducing AGM as well as IOP. What are the limitations? Cost. So how can we reduce the cost? We have Bang, that is we can bend a 26 gauge needle and it works similar to KDB. The other one is GAT. GAT is done initially described by Dr. Grover, and it is 360-degree trabeculotomy. So based on the Schlemm's canal diameter and anatomy, in the nasal angle, it is wider, and even the collector channels are larger. So we prefer to start our MIGs, any MIGs in the nasal angle. And episcleral veins, it helps in identification because once the pressure goes up, there is blood in the Schlemm's canal. Various materials used, there are a lot of costly instruments available, but we can use a 5-0-proline, which is very economical. The tip of the suture is made umbrella tip with the help of a heated metal tip, which helps in easy penetration. So this is my first patient, 8-year-old boy, RD, after trauma, had scleral buckle, AGV failed, then developed cataract. So I've combined cataract surgery with GAT. So initially, it has to be done under good visualization. So you can see the AGV tube there. I prefer to do it from the side port. Once the umbrella tipped 5-0-proline is inserted into the Schlemm's canal, the initial few millimeters we can still see through the lens. So this was the first case. I was not sure whether how many throws we have to give and where is the suture. So I moved the microscope and checked whether it is in place, and I could see that the other end has come, and the first time we do, it's like a wow feeling, and we complete 360 degree. This is a child, PCG, post failed CTT, and then in children it's little tricky. The Schlemm's canal displays posteriorly, so even after the iris fallen back, I've given one more incision, and then I could do the GAT, not completely because it got stuck at the trabecular ostium. The challenges mainly are bleeding and false passage. If the tip of the proline is little large, then it can pierce the sclera, it can pierce the iris, and then it will not go into the correct place. So once the bleeding happens, it's terrible. So initial few cases, these are the problems that I faced. The trick is do it as fast as possible and inject high viscous viscoelastic. Postoperative care, similar to cataract surgery. Pilocarpine used to use it in the beginning because thought of it may form some paths, but nowadays we're not using. This was a publication on how the OCT looks after GAT. So we can see that there is a trabecular shelf which is opened after the trabeculotomy. And you can see the clearing of the trab meshwork once it is done. That patient with CTT and PCG, ectropy on UV are doing well. POAG patient after trab doing well with phaco-GAT. So our experience at 1 year, complete success for 21 millimeters mercury is 70 and qualified is 94. And if it is 16 millimeters mercury criteria, it's 62 and 88%, which are similar at 2 years also. The complications, the most common problem is hyphema, which is like really scary. It's like total hyphema also can happen. But because we have open 360-degree trabecular meshwork, it clears also very fast, like within a week. So this is another patient where the blood was behind the IOL. This takes longer time to clear, maybe even 6 months, and if it doesn't clear, we can do a YAC cap and that can get cleared. Another complication, the complications are very few. Out of some 800, 900 patients that we have done, these are 1 or 2 patients which had severe problems, not really vision threatening. This is one more patient where open angles got converted to closed angles because of a cyclodialysis cleft that happened because of the surgical trauma. So initially, if the incision is not very superficial and if it's deep, then this can happen. But the patient is not having any vision problem or IOP problem. It's like blessing in disguise. IOP is always 8. But once it fails, one of the patients where GAT failed in angle recession glaucoma, and we have done TRAP. And the latest one is the eye stent. We have the older eye stent, which has been replaced by eye stent inject with 2 implants, eye stent infinite, which is going to come with 3 implants. This is my first case with the previous model, and you can see that it's sitting in place. So the learning curve, those who have done congenital glaucoma, goniotomy, it's not very easy, but still, if we have good visibility, the learning curve is not that difficult. How to choose a surgery? It depends upon the cost and the kind of experience we have. So we are comfortable with KDB, bang, GAT, and eye stent because it's costly, not started doing it too many, but we can select. And we know that the number of publications have increased on MIGS with time. So take clinic, it increases the trabecular meshwork resistance, decreases the resistance, and basically used in open glaucomas. And best experience we have had with POAG, PXFG, especially when we combine with phaco. So it has a definite promising role in present as well as in future. Thank you.
Thank Thank you, Dr. Rashmi, for that wonderful talk and also finishing dot on time. Any questions on this MIGS?
We have done, but the success rate is not that great in younger patients. In older patients, they do well, especially in POAG and PXFG. In silicon oil-induced glaucoma, we have done a mix. They also do well, but not complete success. With medication, we have done KDB, GAD also we've done. No. Once KDB